right, it's time to get started. It's so nice to see everyone this fine afternoon. Welcome, welcome. My name is Jamie Seward. I am Senior Associate Director of Alumni Relations with the Johns Hopkins University School of Medicine. Before we start the program, I'd like to acknowledge our sponsor, the Johns Hopkins Medicine Alumni Association. I also encourage you to ask questions by typing them in the Zoom Q&A. It's located at the bottom of your screen. We will definitely have time for questions. We have two amazing speakers here, so I'm sure you're very interested to get to hear them and ask them questions. So John Deming is the Director of Operations at HSS. It's a leading provider of healthcare security services. With over a decade of experience in hospital safety, security, and emergency management, he currently leads the security programs of 30 hospitals across the state of Texas. He earned an MA in public management from Johns Hopkins, and his undergraduate studies were in public safety and security at Florida State University. John is joined by Paul Sarnees, the Assistant VP of Safety, Security, and Emergency Preparedness for Virtua Health, serving Southern New Jersey. He has a bachelor's degree in criminal justice from Rowan University, a master's degree in safety engineering from Warren University, and a master's in administrative science from Fairleigh Dickinson University. So it is now my pleasure to turn the program over to our experts.
Thank you, Jamie. Thank you for that great introduction. So hi everyone. Again, my name is John Deming, and proud Hopkins alumni 2019. Go Blue Jays! So it's an honor to speak with you guys today. And today we are here to talk a little bit about a very important topic that's gaining prominence in healthcare, especially recently, unfortunately, and that's workplace violence. And I think a good way for us to start this conversation would be to talk about first what is workplace violence, right? It's not always the physical violence that we think of with assaults or battery or things like that. So just real quickly, OSHA defines workplace violence as direct physical assaults with or without weapons, but it also includes written and verbal threats, which includes harassment, coercion, things like that that occur in the hospital. So we're here to talk about that subject today. Paul and I have extensive experience in this field, working for security in a lot of different capacities in a lot of different hospitals. And really what we're here to do today is kind of share with you some best practices and things that we have seen and things that we have done in our professional careers, and really impart some of that experience and that knowledge to you guys so that you can in turn take that back to your facilities. And Jamie kind of hit on it before. We really want to keep this interactive. We don't want to show you all kinds of slides and data and all that. I mean, we will touch on that a little, but we really want to keep this interactive and make it beneficial to all of you. So we'll go ahead and get started. And the first thing that I would like to ask Paul is what is the number one issue that keeps you up at night, Paul?
Well, right now, at one point it was COVID, and that was monkeypox, but it's been pretty consistent. I mean, this issue impacts how we recruit, how we retain, how our employees are engaged. It impacts how we provide care for our patients. It impacts our bottom line. And this issue is so bad that the World Health Organization and the World Medical Association declared this an international emergency. And that's the topic we're here to talk about, and that's workplace violence. I mean, the statistics, they are what they are, and they're not good. I mean, healthcare employees are 5 times more likely to be a victim of an aggravated assault than any other industry. The most dangerous job in the country today, and maybe throughout the world, is being a nurse in an emergency department. I mean, there's study after study. There's been over 253 international studies that say the same things, that violence in healthcare is an epidemic in itself. I mean, the situation has gotten so bad that unfortunately, there's news clips and articles throughout the world where we've seen healthcare workers in the Sudan, Israel, Turkey, Canada, and the US have literally walk off the job, have protest marches to bring attention to it, which is good. We want to continue to bring attention to it, but really to demonstrate just how bad it's getting. And unfortunately, the pandemic exacerbated it. And, you know, just yesterday, I saw research that was published by Press Ganey that said every hour in this country, a nurse is assaulted, and 57 nurses are assaulted within a day. The day before that, the American Hospital Association put out an article or a fact sheet, which basically stated that it was 44% of nurses experienced a physical assault during the pandemic, and 68% of nurses experienced verbal abuse while on the job. So it's getting the necessary attention, which is great. But this is an issue that we need everybody to collaborate on to make sure that we are providing our employees with a safe and secure environment, and that the legislation and the criminal justice system supports the enforcement of penalties against those that threaten or assault our staff. And John, you and I both know we've done a tremendous amount of research, and we've been fortunate enough to publish some articles about violence in healthcare. What are some of the approaches that you're seeing organizations take to mitigate violence?
Well, I think that it really starts with buy-in from the top senior leadership within an organization. And really where that starts is creation of zero tolerance policies in a healthcare facility. We really need the buy-in from those executive teams at the healthcare organization level to say, look, we recognize that workplace violence is a problem. We do not tolerate that here, and we will expel you from the facility and we will prosecute to the fullest extent of the law if you commit these acts against our staff. And I think that it's important that us as security leaders and others on this call that are invested, nursing leaders, nursing directors, CNOs, organizations like the ANA, Emergency Nurses Association, all of those collaborate together to bring these issues to the top level leadership and let them know, hey, this is happening, this is a problem, this is impacting multiple facets of our organization, and we need to do something about it. I think that having the input from a multidisciplinary team, being risk management, legal, nursing administration, security, occupational health services, all of those stakeholders within a healthcare organization need to work together to present this to the executive team. And really having that buy-in from the top again is really, really important. There are some states that have enacted some legislation with getting signage put up at different areas of the hospital. I believe I'm looking at it now, that's Ohio that actually put it into law that they allowed healthcare organizations to actually post signage saying that workplace violence is not tolerated here and we will prosecute you to the fullest extent of the law. So I think that getting that buy-in from the top and getting that signage out there, really what it does is it sets the tone for when people come into your hospital. And of course, all of us on the call here, we're in healthcare, right? When people come into the building, they're already at an elevated level, right? They're here to visit an injured loved one or someone who's sick, or maybe, like we just talked about on the call, I just had a baby 9 weeks ago. Is that an awesome, wonderful, beautiful thing? Of course. Is it also a very stressful thing and unknown? Absolutely. So people come into the doors and they're already at an elevated level. And that's something that we deal with every day. But when it gets to that level, where it gets to be to that level of harassment, coercion, physical violence, threatening, it needs to be zero tolerance. And starting there is really what the biggest part of it is. So, besides the policies and procedures and the signage, Paul, what kinds of things have you seen be successful, as being the president of IHSS and being in charge of such a large healthcare organization? What have you seen be successful?
Yeah, well, you kind of hit it on the head. I mean, it starts with senior leader commitment, right? We've all heard the saying, culture eats strategy. So the culture has to be the right culture to really have a successful workplace violence prevention program. I mean, many organizations are on that journey to be a high reliability organization. And boy, this ties right into it when it comes to reporting and non-retaliation and so forth. So you hit it on the head. It starts at the top. The tone has to be set by the senior leaders of the organization. After they define what workplace violence is, the senior leader needs to be assigned the responsibility of overseeing the work, in my mind, and what I've seen successful in organizations throughout the country. When a senior leader is assigned a responsibility for overseeing the workplace violence program, actions are supported. We all know that data is incredibly important. Every decision is made by data. Resource allocation is made by data. So data certainly has to be a big part of that. But besides having a senior leader assigned to it, you mentioned the workplace violence committee, that multidisciplinary committee that's really looking at the totality of the program. So looking at policies and procedures and training and incident reports and so forth. Really having that one, if it's a steering committee or a committee that's overseeing the program, you really need to have the buy-in from everybody in the organization. And certainly those organizations that have paramedics and home care and those that work out in the community. I mean, all those key stakeholders need to be involved in the creation and maintenance of that workplace violence program. You mentioned the committee. Incredibly important to have that committee and the structure in place so that, again, there's a process for approving recommendations. There's a process for allocating resources and so forth. Once violence is defined, and I had the pleasure of sitting on the advisory council for the Joint Commission when they were developing the workplace violence guidelines that just came out in July, and I think Joint Commission has a very good comprehensive definition of workplace violence. And I'll just read it to you real quick. It's any act or threat occurring at the workplace that can include any of the following: verbal, nonverbal, written, physical aggression, threatening, intimidation, harassing, manipulating words or actions, bullying, sabotage, sexual harassment, physical assaults, or other behaviors concerning involving staff, licensed professionals, patients, or visitors. Very comprehensive. But organizations need to define violence and how it fits their culture, how it fits their patient population. The other thing that's incredibly important, and I know the security professionals on the call understand the importance of this, and that's really doing an assessment of the physical environment. If the environment is not supporting a positive experience for the patients or the staff, if there are blind spots, if there are areas where our staff is isolated, where we don't have direct surveillance on our patients or visitors or on our staff, if we're not controlling access into our facilities in the sensitive areas, if we have no clear lines of what is a staff area versus what is a patient area, it's the term of territoriality. So you should be able to really define quickly, where can the patients go? Where can the outpatients go? Where can the staff feel safe that they're in their own space? All of those things really need to be assessed. And they need to be assessed on an annual basis, and they need to be assessed by an individual that has the credentials to assess them. There are a million consultants out there. We all know that. There's good and there's bad, and there's others. But really, the credentials for doing a security assessment really should be specific to healthcare. And the International Association for Healthcare Security and Safety provides a certification. It's an accredited certification. The title is a Certified Healthcare Protection Administrator. That demonstrates knowledge and experience, as well as the testing. So there was the validation that the knowledge is there. So having the committee, having a good definition of workplace violence, doing the assessment is incredibly important. Data, John, I know you're going to speak a little bit about data as we go on, but again, we all know that data drives every decision that is made. Data drives every allocation of resource. So really good incident reporting system that's capturing what's going on. There is the ENA did a study years ago where the Emergency Nurses Association. So they surveyed their employees, their members, and they asked the question, how many of you were a victim of verbal abuse on the job in the last 12 months? And I think it was in the 60%. So 60% of the nurses, yeah, I was a victim of verbal abuse on the job. Second question was, how many of you were victims of a physical assault on the job in the last 12 months? And it was high. I mean, it was close to 40%, if I recall. The third question, I think, is the most telling. Third question was, of those of you that answered yes to questions 1 or 2, how many of you reported it? 3%. So that's culture. That is culture. So culture has to be right to support all these programs. And that's why, John, you said it from the beginning, that's why it has to start at the top. And the leaders of the organization have to drive that culture that's going to support reporting, non-retaliation, and implementing the right mitigation strategies that are going to reduce workplace violence. So committees, definition, data collection, assessments, also training and education. I'm surprised. I do have the pleasure of visiting other organizations and surprised that a lot of organizations don't train staff on how to identify and manage aggressive behavior. They don't teach what the verbal warning signs or what the physical warning signs. And there are a million programs out there. There are some programs, and there's international programs that some provide training and education, where others will actually provide a certification, but where they actually provide education and training on how to identify and manage aggressive behavior. And then just as important, how does staff protect themselves in the event that somebody grabs their wrist or chokes them or bites them or grabs their hair or grabs their lapel. You know, organizations need to provide that level of training to their staff. And the Joint Commission standards now, for those organizations that are Joint Commission accredited, it's required. So anybody that's Joint Commission or internationally accredited through the Joint Commission, you have to provide training and education to your staff. But that training and education really has to be specific to your patient population. So I encourage everybody to do your homework. There are some programs that are really geared towards pediatric population. There are other programs geared towards geriatrics, others geared towards behavioral health patients. So it's really doing your homework, identifying the best training program that's going to match your culture, that's going to match the patients that you serve. And besides all those things, we need to provide our employees with resources, right? So God forbid one of our employees is injured, and the statistics are telling us, right? So before the end of this call, there's going to be 2 nurses that are assaulted in this country. So we have to provide them with, you know, medical care, psychological care, maybe legal services. I mean, employees need to know that their employer cares about them. So, you know, God forbid one of us is assaulted. If we don't get a phone call follow-up from our employer, I'm sure we're gonna have a sour taste in our mouth. If I have to pay for my medical care because I was injured at work, I may not be staying long at this employer. If I have to retain my own attorney to protect or represent me because I've chosen to file a private criminal complaint against a patient that I was providing care to, I was trying to help and heal, I'm probably going to leave that organization. So organizations need to make sure that they're providing their employees all the resources to heal and move forward. And with technology, there's great services today. I mean, most organizations have employee assistance programs, but a lot of that is now transitioning to the kind of the teleworld, telehealth. So there's telepsych services, there's other counseling services. So all of those things that I spoke about are really part of a comprehensive workplace violence program that really, they're proven strategies to mitigate violence. And those are the components of a successful program. And organizations that do that well reduce injuries, reduce assaults against staff. They have better recruiting, better retention, and better staff satisfaction. So we talked about data earlier, John, and I know you're a data geek like I am. so again, data drives every decision we make, and healthcare is all about evidence-based practice, is all about data. So what are some of the easy ways or the best practices that you've seen organizations utilize to collect that most important data?
Great question, Paul. And, you know, I'm looking in the chat here and I saw that there was a Sarah who asked, what were the barriers to reporting? And that's a great question. And that's something that, you know, I plan on hitting on this segment. So really what I've seen the biggest barriers to reporting, and it kind of ties into this, are again, you kind of touched on it before, it's having that no retaliation policy and really having that open door policy starting at the top level down to those directors and managers saying, hey, we know that violence is happening here, we're not tolerating it, we need to know where it's happening, and just know that if you do report this, we will not hold it against you, we will not we will not dock you for it. We will not discourage you from reporting it. And I think that's really the biggest one. It's that nurses and techs and MAs and doctors, they feel as though if they report this, that something bad's going to happen, or they're going to be put under the microscope or something like that. So, all of the leaders on this call, if you're in charge of a nursing unit or if you're in charge of a facility, we need to start with ourselves. We need to really be sincere and not just talk about it, but be about it too. We need to really let our people know that we care about them and that we need to know when this is happening. And I think the second part of it is that I'm sure all the nurses on this call will, understand 110%. I mean, my wife is a nurse too, so I know about how this works. I mean, nurses are required to report and document so many things when it comes to medical charting and checks and scanning of documentation and getting into the Pyxis machine and making sure that somebody witnesses you getting rid of excess meds into the Pyxis. And there's so many reporting requirements that nurses have to do already that I think if we were to add a cumbersome process to reporting it, I think that that's also a pretty big barrier to reporting it as well too. So something that we were able to do at where I previously worked over at St. David's Medical Center is we created a very concise and simple reporting mechanism for workplace violence. What we did was we created a very simple tab on our healthcare system's intranet page. It was a red button that said report workplace violence here. They clicked on it, and really it was just a really simple, when did this happen? Where did this happen? Physical versus verbal, and severity 1 to 5. And they were able to just plug those numbers in real quick. And there was a short text box where if they wanted to put some details in there, they could, but it wasn't a requirement for you to submit, right? So it was something that you can do in under 30 seconds. And it was something that was really quick, really easy, and it didn't add, well, I mean, it did add a little, right? But it minimally added the amount of reporting that medical staff needed to do. And what we saw is over time, of course, right? It requires reinforcement, right, from the leadership. Hey, we want you to report. We want you to report. Let's show you the button. Attending nurse huddles, talking about it at town halls, and showing our medical staff how easy it was and how we're encouraging them to do it. And over time, what we saw is we saw a spike in reported workplace violence events. Now, did that mean that more workplace violence events were going on at the hospital? Maybe, but probably not. It was just that the reporting was going up. So what we were able to do with that information is that we were able to track the information. We were able to see where it was happening, when it was happening, who it was happening to. And with that information, our workplace violence committee, you kind of touched on this before, Paul, we were able to take that data and look at it and make informed decisions based off of that. Because if we don't know where, when, and who this is happening to, how can we allocate resources? How can we work on installing more panic buttons or getting more security staff or changing the way our security officers patrol an area if it's a particularly hot area, or working on those flagging mechanisms inside Meditech or the nursing charting system so that if we do have those patients, and I know we all do, right, those patients that are always in and out of the hospital, and those patients that have either a alcohol or drug problem or a psychiatric issue where they're always violent, right? If we could work to getting those things reported, we could work on getting the funds and the resources allocated to help that. Um, I think that another avenue to helping that would be to create a reporting mechanism inside of the medical charting system, whether that be Meditech or something else. Um, in my experience, I have found that using that really concise part, because Meditech and nursing charting system can sometimes be really cumbersome, click 1, 2, 3, 4, 5, and 6, but if you accidentally missed 2 and 3, then it won't let you do it, and it gets cumbersome, right? I think that that's a start, but I really think that getting it into the intranet and making it really easy, I think is probably a best practice and something that I personally myself have seen be successful. Um, kind of just kicking it back to you, Paul.
Mhm.
What have you seen as some of the best practices to ensure that clinical staff is aware of the high risk patients?
Yeah, great question. I mean, just to go back to something you said about the increase in report, every violence prevention committee should have as their goal, at least in the first year, if it's a baseline year, to have that increase in reporting, the frequency of reporting. You have to prepare your senior leaders for it because, as John said, it may be perceived as violence is increasing when it's not. It's just reporting. So I always suggest that's one of your goals. We want to see increased reporting. But I've seen some really good best practices out there. I mean, our electronic medical record systems, many of them, if it's Epic or another program that you may be utilizing, they do allow us to flag a patient, to put a banner or a flag on the patient that would identify the patient as high risk. The If that's going to be utilized, a process for how a flag is initiated, how often it's reviewed, and when it's discontinued. So just to give you an example, if I have a bad reaction to anesthesia and I act out, and you know that I'm going to react to anesthesia next time I come, I may not necessarily need to be on that high risk patient list. But there are some individuals, as we all know, that come in and they're assaulted every time they come in. So really flagging the clinical record with a banner or flag that identifies me as high risk, but then also gives staff easy, quick access to the plan of care. So Paul Sarnice walks in and Paul Sarnice has a history of acting out. The plan of care could be immediately contact security, assign a one-on-one, immediately contact psych for consult, get them in paper scrubs. Or don't give this medication to Paul because Paul has an adverse reaction to it. So really utilizing the medical record to identify that patient. I've also seen organizations successfully have pushing that information is now pushed to people. So in the same example, Paul Sarnice has a history of violence or aggressive behavior, and there's a flag on my chart. When I come into the ED, I present to the registration, and my information is starting to be typed in, and my medical record number is confirmed. That information is pushed to the clinical leaders in the organization, letting everybody know that I'm in the organization. My organization, we don't have that level of sophistication today. We're working towards that. So what we do is we have a list of 653 high-risk patients in our organization. Every day, one of our colleagues in security reconciles our patients that are in-house. So everybody that's through our admissions, discharge, and transfer database, we reconcile that. And at 7 a.m. and at 3 p.m., we push out a list to each campus, those individuals that have been identified as high risk. And it says Paul Sarnice, medical record, ABC 123, date of birth 111, has had so many contacts with security, 4 elopements, 3 restraints, 1 assault of staff. I mean, it's that level of detail. And it's pretty cool. And the expectation is that information is cascaded down to the caregivers that are providing direct care to that patient. A lot of organizations put flags or magnets or signs on the door that let all the clinicians and all the food service, the lab, the housekeeper that's going in the room, let them know that beyond that door, there's somebody that you need to use caution with. And if you have any questions, stop at the nurse's station to ask why. Because that flag may be there for a couple of reasons. The flag may be there because there's a plan of care for the patient, but there also may be a plan of care that the employees need to follow. So I'll tell you one quick story. We had a plan of care for a patient that was 2 employees must go into the room at all times because the patient had a history of violence. that had nothing to do with managing the patients. We couldn't manage. Patient had a traumatic brain injury. We were not going to have any impact on how they interacted with our staff. So our plan was to manage our staff's behavior. So again, that little magnet on the door told everybody, hey, if you don't know what's beyond that door, stop at the nurse's station to find out what's going on. Because we all know that past behavior does predict future behavior. So it allows our staff to be more prepared for what they may encounter. So those are some of the best practices that I've seen organizations use. I'm sure there's others out there that I haven't heard of yet that are being utilized to really keep our staff safe. So John, you and I talk all the time, and through our association and through what we see on, if it's LinkedIn or the internet, there's a lot of activity going on right now at the state level and at the federal level when it comes to enacting laws that are going to have more teeth to them and more power behind them to protect our healthcare colleagues. So what are you seeing as trends, or what do you think the future holds in that area?
Well, I think that we're already starting to see it, Paul, and I think that it kind of mirrors what we talked about in the beginning of the presentation, right? How it starts at the top, right? It starts at the top level. And what we're starting to see now are some very encouraging things. For instance, there's House Bill 1195 from the House of Representatives, the Workplace Violence Prevention for Healthcare and Social Service Workers Act. So this actually passed in the House in April of last year. So it's currently moving through the legislative process, but really the nuts and bolts of that is that it requires certain employers, including healthcare organizations, to take action to protect workers and their personnel from workplace violence. So it's kind of and that's kind of the big picture look at it. I mean, I don't think we need to get into, line by line of exactly what it's going to require for the purposes of this presentation. But really, we're starting to see that at the federal level where legislators are responding to their constituents and they're seeing what the problems are and they're attuned to it and they're starting to take action on it. There are also several states that are starting to take action as well on this. There are actually 8 states that already require employee-run workplace violence prevention programs. So those are in the states of California, Connecticut, Illinois, Maryland, Minnesota, New Jersey, Oregon, and Washington. So those are already, 8 states that are being progressive at their level to recognize where the violence is happening and then putting forth a plan to take care of it. Way too many states to mention. I'm not gonna sit here and name 38 states, but just know that 38 states have already designated penalties for assaults against nurses. So the vast majority of states are already working towards this. There are some, and it is an interesting caveat, if you happen to be calling from Georgia, Hawaii, North Carolina, South Carolina, Oklahoma, and South Dakota, interestingly enough, their laws are only specific to emergency department personnel. So they actually designate violence against nurses or medical staff that work in the ED only. So they're a little bit more restrictive, but it is a step in the right direction. And something that I mentioned a little bit earlier, the state of Ohio actually has it in their legislation that they passed, that they actually have allowed medical organizations to post signage outside of their doors stating that, hey, we do not tolerate workplace violence. And according to statute, 1, 2, 3, 4, 5, we will prosecute you to the fullest extent of the law. So, I think we're starting to see a lot of traction when it comes to this, when it comes to legislation, and it's very encouraging. But I also don't think that that's any reason for organizations like IHSS or the Emergency Nurses Association or the ANA or a leading figure in medical as Johns Hopkins. I think that we need to keep our foot on the gas pedal and keep pinging our legislators and bringing awareness to the issue and continue to educate and do things like what we're doing right now, just talking about it, giving some light figures, talking about why this is an issue. I think we need to continue to do that. And, Paul, you kind of mentioned it a little bit earlier before, how the Joint Commission has
Mhm.
started to recognize the importance of workplace violence in healthcare. And I think that that could be most greatly demonstrated by their new standard, which is LD 30101. And anybody who's on the call that is a Joint Commission hospital, that LD stands for leadership. So LD leadership, that falls on, if there is a finding for that, that falls on the CEO, that falls on the C-suite of the hospital. So I think that that demonstrates that Joint Commission has realized the importance of it, and they've made it a leadership requirement. And just for all of y'all's information, LD 30101 states that leaders must create and maintain a culture of safety and quality throughout the organization. It requires that the organization define workplace violence and that they develop a program to reduce it. So, if you happen to be a Joint Commission hospital, it is now required. And if you don't do it right, your leadership will be pinged. And I think that that could be a good, maybe not to use the stick tactic with your CEO, but it may not be a bad idea to, when you're bringing this to your O, like, hey, just so you know, this is a leadership Joint Commission requirement now. So, because when you're going through a triennial, you don't want any findings, obviously, right? But you certainly don't want any findings on leadership, because that's a
So,
red. So
yeah.
you
And
certainly don't want that.
John, if I can just add, that was done purposefully. Again, I had the pleasure of being on the advisory council, and the Joint Commission of Leadership purposely put it as a leadership citation because we need the leadership support to make anything happen. And I have a colleague that calls the Joint Commission report the report card for the COO. And it really is. It's their report card to the Board of Trustees. And certainly none of our presidents and CEOs or COOs would want a bad report card. So, certainly it's our responsibility to make our leadership aware of the Joint Commission standard and the data and everything else that goes with the program. But, I live and operate in the great state of New Jersey, and, our laws right now only protect licensed individuals. So if one of my security officers or a one-on-one observer is assaulted, it's a simple assault. If a nurse or doctor is assaulted, it's an aggravated assault. So we're working right now with our state to pass what's called the Heroes in Health, it's the Heroes in Healthcare Violence Prevention Act, which will increase penalties. It will be $1,000 automatic $1,000 fine for threatening a healthcare employee. Doesn't matter if they're licensed or not. And we would be required to post signs at the entrances that would say it is illegal to assault or threaten a healthcare employee. It would automatically be a higher degree of a crime. There's also a judge discretionary, I think it's up to 6 weeks of anger management for the individual.
Wow.
So I think that's a part of it, but I would also encourage everyone to work with your prosecutor, because we could have these laws on the books and they could be law, but you have to work with your prosecutor. We've been blessed to work with 2 great prosecutors over the years, which have allowed our staff to not use their personal home address. If they're signing a private criminal complaint against an assailant, they're using the address of our organization.
Right.
So they don't have to share that information, because the feedback we got from our employees was, no, I don't want to share my information because it's public.
Right. Right.
So I think working with the prosecutor to also go after individuals that assault, and not necessarily having a pretrial intervention and lessening the penalty is just as important in having that law in the book.
Absolutely. Absolutely. Well, Jamie, Paul and I we're pretty efficient here. It's like right on the dot for where we're supposed to give our chat. So I don't think I have anything else to add as far as what I was planning on speaking on. So we're right on the dot.
Yeah, are you able to view the questions in the Q&A?
I am, yes.
So if you want to, feel free to look at those, or I can read them to you.
I can read them. I think the first 2 are similar. Um, A gentleman named Paul mentioned that workplace violence happens both inside and outside of acute care facilities. I mean, I think that that's absolutely true, right? And, there are a lot of challenges when it comes to those offsite and those rural areas because they may not always be staffed by security officers. There may be in an area where there is a low law enforcement presence. And I think what I have seen be successful at these outside acute areas, and an anonymous attendee also mentioned rural as well too. So I'm kind of looping those together. And really, what I've seen is using those force multipliers, what we call in the security industry as force multipliers, being those video surveillance, utilizing panic buttons at the facility. And those panic buttons could either be if you have a robust security program within your healthcare organization that would go to a security operations center, which would dispatch an officer out to that site. But really, what I've seen be most successful is that it's a panic button that goes to local law enforcement, where they're able to press that button. It immediately notifies law enforcement that something is wrong, and it elicits a expedited response from the closest police officer. Something else that I've seen be very, very successful as well is something we're doing in Houston right now with one of my larger hospitals, but this could be done at a rural or a smaller area too. Is that we've been able to have our uh, video cameras on site be viewed by the police department. So if there is something that's actively going on and we notify law enforcement, they're able to go into our cameras and see exactly what is happening in real time so that they could send that information to the police officers so that they could have a great response. I think that, again, being in that rural area, if there is a need for it, I think that also having physical security officers there is a great option as well too. And that's not going to happen though unless there is data that supports it. And that would be pulling local crime data. What types of crimes are happening? How many crimes are happening in that area? What is the severity? What kind of patients are we seeing inside of this offsite? And what kind of interactions are we having? Right? Are we frequently having to deal with upset people? Are we having to put our hands on? Are we having to restrain and chemical restraints, physical restraints? And if those things are happening and we're able to speak to that data, that's what's going to convince that CFO, that COO to allocate some resources to get those electronic safeguards and also those physical security officer safeguards in place as well too. So I hope that answers your question. Um, I will let Paul, Paul, if you can see, there's a Sarah Marie Baumgartner that asked a question.
Hey, Sarah, I always wanted to meet you. I follow you on LinkedIn. Barriers reporting. I mean, I think we've heard them all. One, it takes time for employees to do that. Employees, especially in organizations that don't have the right culture, feel as though reporting is just a waste of time because nothing's going to be done about it. I actually had a violence prevention committee many years ago where that was the feedback we got from the employees. It just takes too long. So we actually did a couple things to make it easier. John mentioned putting it on the front page of the intranet site. That's what we did, put it right there. We also went to a new reporting system that once you start typing in the patient's information, it migrated all the clinical information over. So it was interfaced with the ADT system. We got away from all the free texting, and everything became a drop down. So, I think you're going to hear multiple barriers from different employees, and it's up to us to remove those barriers and make it as easy as possible as we can. And John, I just want to go back to the offsite clinics. I mean, I'm a big fan for developing security standards. So there are standards for an acute care facility, a long-term care facility, an ambulatory surgical center, an offsite practice. We design that for our organization. We take it to the board, we get board approval. Then that information, that becomes gospel. That is the standard as we go forward. Any renovation, any construction follows those standards. For the offsites where there might not be a physical security presence of security officers, I like utilizing public view monitors. We're used to walking into a place. We walk into Walgreens or CVS or Sam's or Costco or any of the other big box stores, and we see ourselves on TV. That sets it's that psychological deterrent that I'm being watched. And that's a tone setter to me. I think the signage that we put at our facilities is a tone setter. And I also think those public view monitors are a tone setter. I think we would all act different. I think everybody acts different when we're being monitored and we know that we're being recorded. So right on that public view monitor, put recording in progress so that they can see that. And I really think organizations will see the benefit of doing that as well.
Absolutely. Yeah, no, I think that's a great idea. You know, same thing, you walk into a convenience store or something and you see your face right there and hey, someone's watching me. I need to act right. So yeah, no, that's great. So I see there's another question here. Do I have to be in security to join the IHSS? Absolutely not. You do not. I encourage you to take a look at the website is iahss.org, and there is a tab there for becoming a member. And if you have any questions, reach out to me personally. I will put my email address in the chat box at the end so everybody can reach out to me. And please use that. I mean it. If I get 500 emails from this presentation, I will be a happy guy. So please reach out to me.
And John, and let me add, the International Association for Healthcare Security and Safety is the only organization that provides a certified course for violence prevention. And anybody that is being asked to lead their violence prevention efforts in an organization, strongly encourage you to attend this 2-day course. It's 2 4-hour segments over 2 days. And a lot of the things that we've discussed today are part of that program. It gives you foundational information to establish a program if you don't have one, how to improve one if you have an existing program, and how to continue to deploy those best practices. And our association is the only association that's truly dedicated to healthcare security, safety, and emergency management. So we have leading practices from all over the world that we share with our members that are available through membership through our association.
There's also very strong local chapter leader presence in a lot of areas in the United States and Canada, and we are growing. So there are many benefits to IHSS membership. So Paul, there's a question from a Kathleen who asked, when an organization forms a workplace safety committee, do you advocate having a patient or family member on that committee?
Great question, Kathleen. So we're actually, in my organization, we're revisiting, because of new Joint Commission standards, we want to kind of refresh it up. And we actually have a sub-team that's all about community engagement. So part of that community engagement will be speaking to the prosecutors. It will also be speaking to our behavioral health colleagues that are in the outpatient world that we deal with. Also reaching out to halfway houses and other residential facilities, but it's also engaging our patients. So, we're talking about going in the future, maybe including some of these, some questions in our patient satisfaction questions about safety. I mean, there was a study that came out not too long ago, I'm sure many of you saw it, where it said a high percentage of the American population is afraid for their loved ones' safety while they're in hospitals. And workplace violence is a part of that. It's contributing to it. So yes, I really think if there's a mechanism to engage the community, family members, and patients, even if it's just for a sensing, like, how did you feel? The security is not something that's necessarily tangible, but it's a feel. So yes, I think there's tremendous value in engaging patients in that conversation. Great question.
Great, thanks, Paul. So I see Lisa asked about the zero tolerance and the role of EMTALA. And many of these patients are extremely difficult to manage and pose a great risk to our staff. And many may be homeless and truly do not seem to be affected by the signage. Of course, Lisa, if somebody comes in with that psychiatric issue or that drug or alcohol intoxication, right? Are they going to read a sign? Maybe, but usually probably not, right? And I think that the best way to overcome that challenge, right, is with EMTALA, right? They need to be seen by someone, right? So I think that when this patient, and what I've seen firsthand as a security officer at a level 2 trauma center that had inpatient psychiatric there at the hospital and physically being there for years as a security officer firsthand, what I saw to be very successful was getting that patient seen in a timely fashion by the physician. Because oftentimes, if the physician is inundated or if they're not having a great day and they go, hey, doc, we have a drunk guy in room 4 and, he's acting out. If we could get him seen by a physician quickly and get him evaluated and, go through those steps through EMTALA, and as long as that physician says it's okay, of course, say, hey, okay, this guy's fine. We can let him go. There's no medical reason why he needs to be here. Let's get him that bus pass. Let's get him that taxi voucher, and let's get him on his way. Or again, there's the other advantage to having a physician seeing is, hey, this guy is acting out. We need to push that Haldol or Ativan or maybe this guy is a danger to himself or others, and we need to place him under that involuntary hold and really do the right thing by the patient, right? So I think that those are really the best ways to do it, is to get that quick assessment by the physician and doing the right thing from the patient in a timely fashion. Because what I've seen as a security officer many times is that it's often the time, right? They're brought in by EMS or by police because they're intoxicated and they're like, I want to get out of here. I don't want to be here. I don't want to be here. And the longer they stay, it builds over time, and then sometimes they explode and it turns into a violent situation. So I think that getting that timely care is really, really important. I hope that answers your question. Paul, I'll kick this back over to you. It's a gentleman named Chris. He said, is there any recommendation on how to encourage staff to sign the complaint? And there is a hesitancy to sign complaints.
There certainly is a hesitancy. I think that's something that we're all dealing with. I always use the example: if you were walking down the street and somebody came behind you and punched you in the head, would you file a private criminal complaint? The answer is majority of us would. It is, for some, it can be time consuming. You are putting yourself out there in the public, but if we don't file a private criminal complaint, and it's really sending a message of acceptance in my mind. So we strongly encourage what we do in my organization. If there is an assault, my staff will contact the police. It's black and white. There's no gray. We will contact the police. It's now up to the victim. New Jersey is a victim rights state, like many states. It's up to the victim to sign that private criminal complaint. And we say to that individual, we're going to be with you every step of the way. You want us to take you to the police department? Put you in our car, we'll take it. You want us to sit with you in court? We'll sit with you in court. Do you need legal representation? Because this happened while you were at work. We have an office of general counsel that could support you if need be. Certainly the prosecutor is one who's representing the employee, but if the employee wants that extra advice, we're going to provide that. Again, there are employees. I mean, we need to keep them safe. So, I've seen some really great practices where security departments hand out a piece of paper that says, this is the process in the state of New Jersey. File a private criminal complaint. You have up to 365 days. This is the number to contact security when you have to go to court. Make sure you're using the address of the hospital, not your private address, and really providing the employee with all those resources to really encourage, but more importantly, to support the employee through the process.
Great, thanks, Paul. So I'm gonna answer the next one here. I'm gonna try to be respectful of everyone's time. I know we're getting to about 7 minutes. Heather mentioned that we found a lot that workplace violence occurs a lot in our registration areas. I think that's perfectly valid, and I've seen that as well. And Heather, what I would say in response to that is, utilizing those force multipliers again, utilizing that monitored video surveillance so that we could see these things as they happen, putting those panic buttons that are directly responded to your security team at those front desk areas, so that when they do, when they do press that button, it is a different elicited response from the officers. They hear it immediately overhead. Hey, security presence immediately needed in registration, second floor, east wing specific, and gets those officers over there in a timely fashion. I'll just take one more too, just to kind of make us kind of move along here a little bit. Lisa mentioned that there are CMS guidelines that hospital security is somewhat limited as to what actions they can take due to being considered healthcare staff. Yes, Lisa, that is true. I think that the best way to overcome that is to make sure that you have a competent and well-trained security staff. Number one, they need to be licensed, right? We need to make sure that our officers have the legal backing and the legal uh, powers of a security officer, whatever state that may be. I'm not sure which state you're in, but all the the laws are going to be varied from state to state. Number two, we need to make sure that our security officers are trained correctly, whether that be in CPI, verbal and physical de-escalation, and we need to make sure that our officers and whoever may be assigned, it may be a sitter, right? It may be an MA who's in charge of dealing with patients. It's going to be different at each facility, but whoever's in charge of dealing with those patients, make sure that they have that de-escalation training so that they know how to verbally de-escalate, and if it gets to that point of violence, that they have the training to uh, effectively restrain and control a patient without inflicting harm to the patient. And as long as we operate within those parameters, I think that we will be okay by CMS. And
And John,
then,
if I can jump in,
sure.
Mr. Rohani is from Singapore.
Mhm.
And he has a question about cultural changes, and I want to answer that question and acknowledge our international colleague that's on the call here with us. The question is, cultural changes may take time in terms of managing workplace violence. What are some effective security-related preventive measures that could be adopted in the short term? I mean, I think quickly security officer visibility. I think public view monitors. I think defining and sharing the definition of workplace violence with your colleagues and having leaders say, we are not going to tolerate this. You have to report this because we want to make sure that we're providing you with a safe and secure environment. So I think those are quick, not, they're not heavy lifts. They're really not. And those are things that could be implemented in a very short term, because we do know change takes time. And all organizations are different in how they accept change. But I think those things could be done pretty quickly.
Thanks, Paul. Mr. Ward, that is a great question. Are you seeing healthcare organizations specifically hire a violence prevention coordinator? Uh, I don't know if you got a crystal ball over there or something, but yes, we are actually starting. I've actually seen that very recently, actually, within the last month or two. Actually, I'm starting to see that there are positions opening at healthcare organizations that are specifically tailored to this role. And again, since it's so new, I can't exactly speak to all of the requirements of those positions, but what I would say is that I would hope that our healthcare organizations are utilizing things like IHSS, things like As Is International, to utilize those best practices and make sure that we are hiring those that are qualified, right? And that doesn't mean they have to be in a security background. They could be a medical background or risk management or clinical nursing even. But as long as they have the credentials and the experience in it, I think that it could be a wonderful tool. And I think that aside from the legislation, aside from all the articles coming out from the ENA and the ANA and all the different journals, I think the fact that we're starting to see organizations create these positions, I think that that's another testament to how much of an issue and how highlighted this issue is becoming. And there's already actions being taken at the organizational level to address it. So yes, Mr. Ward, that's a great question.
Yeah. And John, if I can just add, the best practices I've seen have an employee dedicated to this. It's not something that's added to our plate. It's not something that, is added to somebody that doesn't have the bandwidth to already do it. It's a dedicated resource. I've seen it be successful with security leaders, clinical social workers, licensed clinical social workers, and employees that have certification in drug and alcohol counseling. I've seen some really great practices, but the best and the most mature programs I've seen have a dedicated resource.
You want to take that last one, Paul?
Oh, I'm sorry. Which one is that?
Do you use the violence incident log to build metrics and any best practices for data to collect and show on a dashboard?
Yes, absolutely. So, when I do assessments of organizations, I always ask the question, and you can tell pretty quickly where they're at and their maturity level is. All right, what unit has the most incidents? If you can't answer that, you're not mature in your program. Because most will say behavioral health in the ED, and that's not necessarily true. The majority of the organizations, it's going to be in their med surg units. So, yeah, those metrics are really, really important. Date, time, location. Um, Cause of injury, type of injury, body part injured, occupation of the injured, lost days, modified duty days, cost of injuries. Those metrics are the ones that get our leaders' attention. So those are incredibly important. And many of us struggle with where's the source of truth for that information? Is it in the incident report? Is it in OC Health? Is it in employee health and safety? Is it in the leave team? Who has it? But you have to really determine where that source of truth is, and then really utilize those metrics to tell your story. I had this unfortunate situation where I walked into a leader's office I was invited to talk about violence prevention, and I looked at the data, and I unfortunately was the one that had to tell them that the organization had a 154% increase in violence over the last year, and they heard it from me, not from within their organization. And certainly, it just really kind of demonstrated the lack of maturity on knowing their own data. So those metrics are incredibly, incredibly important, and they help you develop your KPIs. Once you develop your program, what are you going to monitor going forward? Is it lost time, modified time, frequency of injuries, OSHA reportable injuries? All those different things will then kind of drive how you're going to manage your program.
Great. All right, Jamie. We are an efficient couple of guys.
You are. It's incredible. And I really appreciate your time and your talent. I have a very dear friend of mine who was a victim of some violence at work. She's a nurse and she's really struggling. So I'm going to share this with her because you have provided a lot of great information. So I want to thank everybody else for your time joining us today. Especially a huge thank you to our amazing guest speakers. I will share a follow-up email that will include a recording of the program along with a list of resources and our event schedule. And we hope we will see you again soon. So I'm so glad we finally made this happen. Great job. John, enjoy your baby. Paul, stay healthy. Everybody have a wonderful weekend. Thank you so much.
Thank
Bye.
you. Thank you.
Stay safe out there.